injuries in hands and its rehabilitation. Before the topic, I request all of the participants to kindly switch off their video and mute their audio, please. I request all the participants again to mute their audio and video. I would like to invite our guest, Dr. Vaishali Srijit. She's a Joint Secretary of IAP Karnataka with 10 years of academic experience. She's a Vice Principal at Dr. M.V. Shetty College of Physiotherapy. She's a BOS member of RGHS and she's a Vice President at Sports and Fitness Training Federation of India. Over to you, Dr. Vaishali Srijit.
Thank you, Dr. Bhavna. Good afternoon, everyone. It's indeed a moment of great honor for me to be here with you all today. And I take pride, in fact, to be a part of this Karnataka chapter and also a Women's Cell team. The way the Women's Cell of IAP Karnataka is blooming to such great horizons under the vision of the President, Dr. Smita ma'am, and her team. I'm really very happy and glad to see them going to such great horizons on these things. And also, I'm also very much inspired by her enthusiasm, Sumita ma'am especially, and the way she is, spreading her branches of Women's Cell all over Karnataka in district-wise, and then under the district making a team and all that. It's really, I'm happy and I'm also very proud to be a part of you. And for today, to see such great speakers, it's truly remarkable, and they are such expertise in their fields. Dr. Srikant, Ms. Mamuni, and Ms. Swarna of Manipal Hospital. I'm very much confident that this session is going to be really great and very fruitful for all the students who have come here for participating in this webinar. And the topic, surgical management of tendon injuries in hand and its rehabilitation, it's really one of the things which we need to always learn and learn. So I'm very thankful and grateful to the team for coming here and sharing their practical knowledge about all these things with our delegates. Thank you very much for inviting me to be giving an opening speech. Thank you so much to the team of
Thank you, ma'am, for your presence and your encouraging words. With people like you, will continue to do more things for the IAPWC Karnataka. Now we would like to invite our speaker, Swarna Pradhan. She's an occupational therapist at Manipal Hospital. Over to you, Swarna. I request all of you to kindly mute your audio and switch off your video, please.
Slide on the desktop, Swarna, PM or webinar on the desktop.
I can speak now?
Yeah, thank you.
ಈಗ ಕ್ಯಾಬಿನೆಟ್ ಎಲ್ಲ ದೀಪಕ್ ರೂಮ್ ಇದೆಯಲ್ಲ ಡಾಕ್ಟರ್ ದೀಪಕ್ ವೆಂಗಗೋಪಾಲ್ ನಾವು ಬರ್ತ್ ಸರ್ಟಿಫಿಕೇಟ್ ಮಾಡಿದಿರಲ್ಲ
அந்த பையன் அந்த பையன் ரீதி தேவை இல்லாத இன்னும் கை சேர்க்கல அந்த கை
coming, so it's not visible. Slide.
No. From the beginning.
Start from beginning. Okay. Good afternoon, all. First of all, thanks to Manipal Hospital, Bangalore, and IAP WC Karnataka to give the opportunity to speak today about post-op management of tendon injury. What is tendon? First of all, a tendon is a tough band of fibrous connective tissue that connects muscle to the bone. And when the tendon injury actually occurs, sharp trauma, when crush injury or sports injury, or any rarely due to spontaneous rupture, tendon injury may happen. Why do you need therapy? To optimize hand function after injury. Aim of therapy is to protect the sutured tendon against the stretching, rupture, prevent and treat the adhesion, allow full range of function or movement. Why it is important to exercise? Exercise is important to allow the tendon to heal, reduce stiffness and swelling. Mainly during the therapy period, after surgery, we have to do the minimum 2 hours gap, 5 repetition of exercise program. Too much and too little exercise is dangerous because it may rupture the tendon or may create the adhesion. What are the treatment goals followed by the therapist? To establish normal hand function, to prevent tendon rupture, promote tendon healing, prevent adhesion, restore passive range of motion and active range of motion, edema control, and pain control. Prognosis. Prognosis depends on age. What is the age, kind of injury, burns, joint involvement, delay in therapy, improper immobilization, medical condition or localized condition. What can a therapist do? First of all, one therapist when get one tendon injury patient, first therapist has to assess or evaluate. Once patient evaluation finished, then we have to analyze what is the actual area of problem is there, and we have to, according to that, we have to set our plan a treatment goal. Second is, if any which part is injured part, we have to fabricate a spline to protect that part. Then recommend a home exercise program to continue that. Then next is apply techniques to reduce swelling, prevent further damage or injury. Then show the patient how to complete the activity safely and independently at home. Then incorporate the patient goal and set a treatment plan. Non-standardized assessment. Mainly we have to check when evaluation is coming, that is two types of evaluation we have to do. One is standardized evaluation and another is non-standardized evaluation. In non-standardized evaluation, we have to check the age, gender, appearance, which area of injury or zone of injury it is. Then edema measurement, range of motion through goniometer, muscle strength through MMT or dynamometer we can use. Then sensory examination through Sinstein monofilament. Discriminator we can use for the moving touch. Then turning fork we can use for the vibration checking. Then hand function assessment we have to do. Mainly the areas is reach, which type of grasp is affected, prehension, what type of prehension is affected, in-hand manipulation and release. And special test if needed, we can do the Phelan test, Tinel test or reverse Phelan test. Then come to the standardized assessment, that is so many assessment are there, but I'm just going to give few of them. One is total active motion through total passive motion, 9-hole peg test, Jackson-Taylor hand function test, then disability of arm, shoulder, hand questionnaires, which is called DAS. We can use also quick DAS for the easy review, and Primus, which is available in Manipal, that we are using for the assessment and treatment purpose also. Now I'm going to give the slide to the Dr. Srikant.
Hello, good evening, everybody. First of all, I would like to thank IAPWC Karnataka for giving me this opportunity to address all of you. I'm a plastic surgeon by training, and I'm a hand surgeon also. I see a lot of hand injuries. I treat a lot of hand injuries, both simple and complex. One of the main reasons why we are all worried about the hand is that if the hand injury is not treated properly, then the patient has a lifelong disability. A small simple injury which could have been treated well ends up with a complicated matter which leaves him with a disability lifelong. This becomes especially important in people who are using their hands a lot, like say somebody who plays a veena or a guitar or a piano or a keyboard, or is musically inclined and using a tabla. In such people who use their hands more frequently, and the talented people, if we do not give them the right kind of treatment, they will end up with a lifelong disability. And unfortunately, if it is their profession, they stand to have a huge loss in their profession. The reason why we have chosen flexor tendon and extensor tendon injuries as today's prime talk is that these are very common, and if treated properly, we can give good results. Coming to the flexor tendon injury as such, these are all complicated. The reason why they are complicated is because of the anatomy of the hand. As you can see on your screens, this is the basic anatomy of the annular and the cruciate pulleys of the hand, which gives us all these problems. The flexor tendons, the FDS, the FDP, pass through all these tendons, the tendon sheets, and get inserted into the different parts of the bone along the phalanx and help to move the fingers. Whenever the tendon is injured, then it doesn't allow the joint to move, right? The reason why these different pulleys and ligaments exist is to decrease what is known as the moment arm. If you can see on your screen, the distance between the axis of the joint and the tendon is known as the moment arm. The pulleys here and here reduce the moment arm. If the moment arm is less, that is the distance between the joint axis and the tendon is less, then the function is more power is transmitted across the joint, and the flexion is more powerful. In case the moment arm is increased due to a loss of the pulleys, then what happens is that there is something known as a bowstringing which happens. So the tendon moves away from the phalanges, and then the hand becomes weak in its prehension. For ease of understanding and treatment, there are different classifications. Classification just help us to treat. No injury comes specifically saying that I will come and attack zone 1 and zone 2 and zone 5. But these help us to understand, based basically on the anatomy of the hand and the fingers, and they're classified in the flexors between zone 1 to zone 5 and extensors between zone 1 to zone 9. Zone 1, you remember, is the insertion, and zone 5 is the musculotendinous unit or the muscular unit of the muscle. Between that, we have zone 1, zone 2, zone 3, zone 4, and zone 5. Similarly, extensor tendon, because extensor mechanism, is a much more complicated mechanism. It receives different kind of tendons. It is not finally, and it goes in, it is not a tendon, it is an extensor expansion, and receives different muscle subunits, and hence has got more number of zones. The clinical implications is the sooner we treat a tendon trauma, we get a good result. That is the general principle. In case you operate on day 0 or day 1, you give good physiotherapy, then you can get finally a good result. But however, if you, for some reason, if the general condition is bad, specialty is not available, you can do something known as a delayed primary repair. A delayed primary repair is preferable to be done in the first 2 weeks. It is can be extended up to a month, but beyond that, what happens is that the muscles and the muscle fascia start contracting, and the tendon ends may not meet, and you end up with either a contracture, or you may feel that the tendon is shortened so much beyond its ability to come back to where it is needed to be repaired. But up to a month, we can afford to wait. Coming to the flexor zone 1, it is the distalmost part of the flexor zone. This is typically, you can remember it as a FDP insertion, that is the flexor digitorum profundus is inserted. It is a single tendon. It is difficult to treat this because there is not enough tendon stump left on the distal end to stitch it. Different kind of grasping sutures, as you can see, has been shown. Sometimes we may have to use something like a button to pass, drill the nail, drill across the bone and bring it across the nail and stitch it over a button. Sometimes we need to use a multiple grasping sutures because the tendon is very difficult to hold there, and a single grasp may not be enough and may cut through. You can place the tendon either on the nail or on the distal end, depending on how it is. If the cut of the injury is little more proximal to the joint, then you may be able to repair it even with a proper modified tendon repair, like a modified Kessler repair. The zone 2, this is known as the killer zone, or the most difficult zone in all hand injuries to treat. This is where our today's topic of repair and rehabilitation is going to pay maximum time to, because it is very difficult to get good results in this zone, and badly treated zone 2 injuries will have a lifelong deficit or a disability. What are the problems here? 1, it has 2 tendons, the FDS, the FDP. 2, it has a tight space. These are the area where we get the poorest of results, and maximum amount of care by the occupational therapist is required here, right from the first post-operative day to extending to about 2 to 3 months. A good maxim to go by is the patient should be able to get a full flexion and a full extension. Therapy stops when the patient has got a full flexion and a full extension. The zone 2 again is divided into a distal, middle, and proximal part. In the proximal most part, the flexor digitorum superficialis splits and goes behind, and therefore in the middle part and in the distal part, the flexor digitorum profundus is more superficial than the flexor digitorum superficialis, and it gets inserted. These are all technical details. These you need to know this. Especially surgeons need to know this, because you need to know where the tendon will lie and which tendon you are going to repair. This also gives us an idea as to what kind of repair that needs to be done in the distal part, in the middle part, in the proximal part, whether the pulleys need to be reconstructed, which are the pulleys that need to be preserved here. These are all the technical details which happen during the surgery. Zone 3, you can see the mid-palmar space. Zone 4 is under the carpal tunnel, and zone 5 is proximal to the carpal tunnel. These are the different kind of sutures that are used: the Bunnell, the modified Kessler, the double Kessler, the Tsuge, the cruciate. All these look a little zigzag and wavy and multiple levels. The reason being that the tendon is a longitudinal structure. That is, it runs from here to here, like multiple strands of hair going like this. If you try to catch it with one stitch, it may not be possible. It will cut through. So you have to form a crisscross or a grasp, as it is told in surgical terms. You can have a single grasp or a double grasp or a triple grasp. Depending on the experience of the surgeon and the kind of suture material, you can have multiple grasping sutures. These grasping sutures are the strength-giving sutures to the repair. This grasping sutures is what allows the therapist to do early mobilization. If this stitch is not done well, you're going to end up in gapping or stretching or even rupture of the repair, which requires a repeat surgery. So maximum care is taken by the surgeon at this stage to have a good grasp. He can go choose a double grasp, a single grasp. The most common grasp in India that is performed is what is known as a modified Kessler stitch. It starts at one end, goes through the outside side, comes back, goes around, forms a 8, and then comes back, and the knot lies in between these two. There are different reasons why to do it. A Bunnell stitch will have the stitch outside the tendon with nothing inside. All these are done because this place has got the maximum amount of complications, and this is any zone 2 injury has got very poor results. We are also able to do a grasping stitch in this area because these are all rounded tendons here. I will explain why rounded tendons when we come to the extensor expansion, where they are more flat tendons, where you need to use a box stitch. Right. The other thing is that we need to do a good epitendon stitch. Why we do a good epitendon stitch is because adhesions are maximum in the zone 2 area. You may not need to do an epitendon stitch in any other place, but a surgeon should have done an epitendon stitch in the zone 2 so that you can get early good gliding. If we miss to do this, what happens is the tendon and snag underneath these pulleys and the ligaments there, and they don't allow easy gliding. And if there is no easy gliding, it causes the patient pain when you give early physiotherapy, and the patient does not turn up for repeated sessions because of the pain. Adhesions happen, and you end up with a poor result. Zone 3 is another zone which is known as the mid-palmar space. This is the area where muscles, nerves, and vessels are very closely applied to the tendon. So typically, you will never get an isolated tendon injury here, like in the zone 2 or zone 1. It will be accompanied with the nerve injury. Typically, here it will be the common digital nerves. Therefore, the people will have anesthesia distal to the injury. Vessel injury is common, but rare to have a vascular compromise distally, because the hand fortunately is blessed with a very good circulatory system, and from the adjacent areas blood circulation can go there. However, in the zone 3, if you have a very deep injury right up to the bone, including fracture of the bone, sometimes the collaterals are not enough, and then the finger blood circulation is compromised. We always repair the blood circulation, solve the blood circulation by repairing the vessels also, because sometimes these people may end up with compromised blood circulation, and that leads to what is known as the Raynaud's phenomenon. The soft tissue atrophy is there. It is painful, it is difficult, it is stiff, and very difficult to manage. So it is always better to repair the vessels and the nerves, even if the circulation is intact, because especially when they go into cold regions, or if they do excessive, there is excessive use of the hands, they may go into a Raynaud's phenomenon, which is very difficult to treat later on. Zone 4 is the carpal tunnel. I'm sure all of you are familiar with the carpal tunnel and carpal tunnel syndrome, and especially those of you who have been doing a lot of therapy, you may have realized that the patients come, when you start doing hand therapy, carpal tunnel syndrome becomes obvious. One thing to remember in these injuries is all the structures are very, very, very much ulnar in the carpal tunnel. That means to say, if your injury towards the ulnar aspect of the hand, more tendons are likely to be cut. The flexors, the nerves, the vessels are more likely to be cut in ulnar injury, whereas if it is a radial injury, the number of structures that are cut will be comparatively less for the same depth. Zone 5, it is known as a spaghetti wrist. This is common, especially in sport fights. All the tendons are cut. When you open the patient, you will find it's called as a spaghetti because when you explore the wrist, you will see all the proximal ends of the tendons, each individually, distal ends all opened out, the median nerve, the ulnar nerve, the radial artery, the radial ulnar artery, that corresponding vena commitans, all of them will be cut, and it is known as a spaghetti wrist. When you open it out on the operating table, it looks like a bowl of spaghetti, and that is why it is called. When you hear the word spaghetti wrist, you must understand that it is a complex injury, multiple tendon injuries, multiple nerve injuries, and therefore recovery and rehab will be very long. Along with the motor rehabilitation and tendon rehabilitation, you also have to concentrate on the sensory rehabilitation. That is something that a lot of people tend to forget, because beyond this, the sensory rehabilitation becomes very important, especially in these two fingers, that is the thumb and the index finger. The thumb also has got zones. However, they were a little separate. The pulley system is a little separate. That is, as you can see anatomically, this is the A1, this is the A2, and the oblique pulley. We don't have the cruciate and the annular pulleys. That is replaced by the oblique pulley. And the reason why that happens is because thumb is at opposition, that is at 90 degrees to the plane of the palm. That is because we are different from monkeys and primates, so that we have a thumb which is opposing and helps to grasp objects, both a pinch grasp and a power grasp. The thing to remember is FPL is a very, very strong tendon. It is prone for retraction, and digital nerves are more volatile. From a therapist point of view, what do you mean by prone for retraction? That means if the injury is here, the surgeon may search all the way till here to remove the tendon and pull it out. So your therapy should not stop here. It has to go all the way to the proximal end of the wrist. Stiffness will start from there. Adhesions will start from here. So whenever we look at the operative notes, when you say retracted tendons, when you say multiple incisions, what the therapist in a discharge summary you need to know is that the surgeon has found more and more difficulty in the operating table and has disturbed more of the anatomy, right from here till here or from here till here, to in order to get the tendons. And when he does that, their tendons become more sticky. They are more prone for adhesions. And if there are adhesions, they'll be finger be flexed. If the finger is flexed for a long time, it will become a contracture. Contracture, which is first mobile, will finally become fixed, and it gives you a miserable result. Therefore, it is important for you to read the notes. If you don't have it, not mentioned, please ask your surgeon. Ask him, did you have difficulty? Was it simple surgery? That is enough. If it's a straightforward surgery, you know what to do. If it's a difficult surgery, you tell the patient, you need to come back. You need to come regularly. You need to come daily. You need to do things at home. Only then can you offer a good result. The extensor zones also are there. These are less prone for contracture and rupture, fortunately, because the wound healing is good. The reason why they don't have any adhesions or much adhesions is because the flexor muscles are much more stronger than the extensors, and they allow for easy gliding. Other thing is that there are very few pulley-like systems along the extensor expansion, except with the extensor retinaculum, and therefore there is very little chance for it to get stuck. There is a good amount of loose areolar tissue. All of you pinch the dorsum of your hand, you will realize that the skin is not so tight. So it allows for easy gliding. And good anatomical repair will give you good results. You have many different zones. The zone 1 is depends on the distal phalanx. The more further away, the more distal you see the injury, that means the skin cover is poor. So as a therapist, you need to take care. And if your therapy is going to be aggressive, especially in multiple tendon injury where both the flexor and the extensor, tell the patient or delay the patient's suture removal. Tell them that we will do more aggressive therapy, but don't do early suture removal because the skin cover is poor. The skin will not hold well. These kind of injuries, can be closed, can be open, and the common kind of mallet fingers will be treated with a K-wire like this. Or if it's a closed one, you can give a mallet stack splint, which needs to be continued for 6 to 8 weeks. A zone 2 injury has got different parts. It has got a central slip and a lateral band. We need to bring this extensor tendon to correct orientation and repair it well. The problem here is that typically the sutures tend to be felt, especially when you do therapy. Not to worry about it. These are not very major problems. Just give me a minute, please.
Yeah, because some technical issues. So right now IAP is a host and you are the co-host. Now, now the option is not coming. And Bhavna also I can't. I just check it. No, I can't control here. Yeah, I got Bhavna. So shall I mute or unmute? Yeah, I'm putting in video. I asked to start the video. Yeah, so Dr. now can start.
Okay. Right. We were at extensor in zone 1. We have moved on to zone 2. It's a fairly straightforward thing. It's an anatomical repair. These people need to have a prolonged immobilization, which we will come to as we progress along with this session. Zone 3, we have to remember the lateral bands can be known. The lateral bands are what cause this movement. Okay. So these are common with puncture wounds. It is important to repair these bands separately and so that we have a good result. Zone 4 is over the knuckles. Almost all wounds in this knuckles will need exploration, even a small punctured wound, because typically when you're flexed and you hit somebody or somebody hits you here, your tendon is under tension. Even a small, sharp puncture wound can slice through the tendon. It looks like a very small wound. Over a period of time, the wound will heal and then the patient will present with an extensor lag. So all wounds will need exploration. If at all you any zone 4 you see the injury over the knuckles, we have to tell the patient that they need to be seen, preferably under in the operation theater, but definitely under all, even under local anesthesia you can see. This is similar to sharp blade and puncturing on a stretched out rubber sheet. It will just slice through it. So the tendon just will get shredded even with a small injury. Therefore, that is one thing that you have to remember in the zone 4 injury, that any knuckle wound will need an exploration. Zone 5, these are all big tendons. They do not retract. A modified Kessler stitch, which we discussed in the flexor zone, can be used. The other stitches, other zones, we cannot use a modified Kessler stitch and we need to do something known as a box stitch. Now, coming back to zone 2, I'm coming back to zone 2 of the flexor tendon injury. It is important to remember in that zone 2 that we have the maximum amount of work for the therapist. The surgeon has to take care, because any zone 2 injury, a good surgical technique will always give rise to a nice post-operative result. The attention has to be paid to exposure. That is, it is almost impossible to repair a zone 2 with just a cut injury that you see, even if it's a small cut here. We will have to explore the finger that will proximally and more proximally and more proximally. I'm sure that our therapists, when they've seen my patient, they know. Patient will tell, I had a small cut here, but the surgeon has opened somewhere here, 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 here. You'll be wondering why, what did he do all the way there? The idea is not to damage any of this important structures like the pulleys and the ligaments. We have to thread these tendons delicately all the way from here. It's okay to open the skin, but it is not okay to damage the pulleys. So you will see that a lot of these people when they work with me, they see that there'll be a patient will say, I had a cut here, but doctor made a cut from here, here, some 5 different places. That is important. It is important so that you have an atraumatic technique. Attention to detail is makes the most important thing in any hand surgery. Pay attention to the ligaments, the pulleys, the nerves, the digital vessels. All of this make results to come out very well. The other thing is, again, tendon grasping, as I told you, not to hold the tendon many times. If you hold the tendon once, that should be the first and last. You hold the tendon, thread it through, pass your stitch, tighten it, leave it there. You keep holding the tendon again and again, it keeps shredding and shredding and shredding, and eventually it's trying to stitch through a ball of thread. You will never get a good repair. As I've discussed before, core sutures and epitenon sutures are there. Core sutures are the grasping sutures. Very many things are there. In India, at least in my practice, the most common core sutures that I use is the modified Kessler stitch, where the knot lies inside the gap of the cut ends of the tendon. I also put a running epitenon stitch. The typical suture material I use is a 30 or a 40 Proli and epitenon stitch with the 6-proline. The things that we stress on in a zone 2 injury is early supervised mobilization. A lot of research has been done. A lot of people who are doyens in this field, like Kleiner, Duran-Hauser, have described it. All their papers have shown us that early mobilization, supervised mobilization, is far superior to any other kind of post-operative care. Now, we're coming to the post-operative management of flexor tendon injuries. I will take your questions in the end. Please write it down and send it to me.
Good afternoon, everyone. So now, I'll be discussing about post-op management of flexor tendon injury. Okay. So the rehab management has been divided in 3 parts, like immobilization, early passive mobilization, and early active mobilization. So immobilization, it depends upon the injury. Suppose it is a zone, as sir discussed, it is like, suppose it is in zone 2, the immobilization should be it should be there for 3 to 4 weeks. Like, as the zone are very prone for injuries, those zone needs to be immobilized for 3 to 4 weeks. And then after immobilization, we do early passive mobilization. In this, actually we mobilize the mobilize the tendon earlier. So in this, what happens, the tendon gliding happens properly. So in this method, it has been seen, as we mobilize the tendon passively earlier, the result has been shown, actually, as the result has been come actually good. And then early active mobilization, we start the active mobilization of the repaired tendon, like with proper caution, within prescribed limit, as like prescribed limit by the surgeon. And then I'll be discussing next. So, as I've discussed, control passive motion, like mobilization. In immobilization, there is no proper, no one has described properly. So the immobilization, it is fixed. So for the injury, it will be fixed for 3 to 4 weeks with the splint. And then we start the control passive mobilization. It has been given by Duran and Hauser. Control passive mobilization, there is 3 to 5 millimeter tendon excursion after repair, which is good for the tendon, which is good for the tendon healing. And then in this early passive mobilization, from third post-op day, the patient begins twice a daily exercise. Uh, and then in this protocol, the wrist would be kept in a 30 degree of flexion, MCP in 70 degrees of flexion, and IP will remain neutral. And in this protocol, after 4.5 weeks, the dorsal blocking splint, which we start from the immobilization stage, will be removed, and the rubber band traction will be attached to the wristband. And then active extension, and in this splint, we give active extension and passive flexion, so which is sufficient to prevent adherence of the repaired tendon. So, and then we'll come to the early active motion. This is as given by Cleanert. So in this, what we allow the active extension, but passive flexion we give. We don't give early active flexion. So in this, with the blocking, with the dorsal blocking splint, we give rubber band which is attached to the fingernail of the involved digit. So dorsal blocking splint with, in this actually dorsal blocking splint will be, the wrist will be held in 45 degree of flexion, and MCP joint will be held in 60 degrees of flexion, and PIP will be in gentle flexion. So this method minimizes the scar adhesion and the tendon nutrition, and increase the blood flow to the tendon. And in this protocol, the patient wears the splint 24 hours, 24 hours a day for 3 weeks. The patient is instructed to actively extend the finger several times a day with the splint, allowing the rubber band to pull the finger into flexion. Patient must be able to fully extend the IP joint actively within the splint to prevent the joint contracture. Splint is removed by 3 weeks depending on the surgeon's judgment. And now we'll be discussing about flexor tendon. So this is zone 2. So in this, what we do, 0 to 1 week post-op. First, we do, after removal of the post-op dressing, we maintain the wrist and digit in protected position at all the times. There will be no active finger flexion. And then within the dorsal blocking splint, the wrist will be maintained with 30 degrees of flexion, and the MPs will be positioned by 0 degrees of flexion, and IP will be positioned at the neutral position. And in this phase, we do the edema reduction techniques also. We take care about the edema also, and then we take care about wound, and then we educate the patient for constant splint use. Without the surgeon's instruction, the patient is not allowed to remove the splint. And then we prescribe, like we give the home exercise program, and that includes passive flexion of each individual joint of 10 repetitions for every 1 to 2 hours, and then extension, active extension of each digit within the limit of the splint. And then after the first week, we first, then next first to 2 week post-op, after the suture is removed by 10 to 14 days, the passive range of motion would be continued. And then by 3 weeks, we begin place and hold exercise. In that, we have to instruct the patient to use 50% of the muscle power, so that they will not overstretch their repair tendon. And then patient should be specifically instructed to avoid composite wrist and digit extension. And in this protocol, in this third week, the patient should continue with the passive range of motion, and then with the dorsal blocking splint. And then 4 to 6 week, the you can ask the patient to start the home exercise program. If it in 4 to 6 week, what we see, if at all a patient is having less flexor tendon glide, then we ask the like suppose how we test, we'll ask the patient to hold the flex position. If at all the patient is not able to do, we start early gentle active flexion by 4 to 6 weeks. So in this, if at all the patient is not able to do that, we with the surgeons, if the surgeon allows, we can ask the patient to go for a forearm based palmar nighttime splint, which prevent the flexion contracture. And then 6 to 8 weeks post-op, we have to continue with the active and passive range of motion, which include composite wrist and digit extension at 6 weeks of post-op management. And then add tendon in by this 6 to 8 week, we can add tendon gliding and blocking exercise. And in this 6 to 8 week, we can start trendening and light resistive exercise also we can start by 6 to 8 weeks. So as I have discussed all the things like the management, of flexor, the zone 2 injury, it will be the same, but few differences, like as zone 2 is very prone for adhesion and scar formation. So the main thing in zone 2 is you have to take care, like active motion by 4 week we should start, and passive flexion is allowed, but passive extension is not allowed till 5th week. So by 5th week, we'll start tendon gliding exercises. And after 6 week, in this zone 2, we'll start tendon gliding exercises and blocking exercises. Isolated blocking exercises, in the sense, isolated tendon gliding exercises we can start. So I'll go again with zone 1 to 5. It will be same, like 0 to 3 weeks post-op. Same as like we have to remove, like after removal of the post-op dressing, we have to take care about the edema, and then if at all any wound, and then uh, with the, and how to position the same, like in this, wrist would be at 30 degrees of flexion, as it was same in the zone 2 also. Empty joint only at 50 degrees of flexion. IP joint will be at neutral. So in this week, you can start passive flexion to each visit, and with 0 to 10 repetition every 1 to 2 hours. Then active digit extension within the limit of the splint. And then by 10 to 14 days, we can, by 10 to 14 days, we can start scar massage, and then protective intrinsic stretch exercises can be started, and then we can give elastomer or other pressure dressing, which is helpful for flattening the bulky scar. And then 3 weeks post-op, as I have discussed earlier, in 3 weeks we can start place and hold exercises. And patient, same, like patient should be instructed using 50% of the motor power only, because if the patient uses more than that, there is a chances of rupture. So that is the reason why I asked them to use the 50% of the motor power only. Then we can adjust the splint with the wrist neutral to because the wrist will be in flex position. Then we can adjust the splint to neutral position. And then 4 week post-op, you can continue place and hold exercises. What we extra add in this phase, we add tendon gliding exercises, that is called differential tendon gliding exercises. And we can discontinue the dorsal blocking splint. Advanced exercises program can be started, like active digit flexion, then blocking exercises like isolated tendon gliding exercises we can start, light resistive exercises also we can start. And after 8 weeks, by 8 weeks also, we can start the strengthening program. Sorry.
Keep talking, keep talking.
So I will end my slide here. So like, thank you everyone to give, thank you IAPC to give me this opportunity to speak and share my knowledge about this. So I'm very thankful to share my knowledge. So thank you. So any question, if at all you have, you can just write it down and you can just ask me later once. So now I can Now I'm switching on to Swarna, my fellow colleague.
Thank you again to giving me the opportunity to speak again. Now I'm going to continue from the extensor tendon zone. As Dr. Srikant described extensor tendon zones. This is the tendons zones, extensor tendon zone 1, which is in DIP. Then zone 2, it's in middle phalanx. Zone 3, over the PIP joint. Zone 4, it's over the proximal phalanx. Zone 5 is over the MP joint. Zone 6, over the dorsum of the hand. And zone 7 is the wrist extensor compartment. And zone 7 is the extrinsic muscular compartment. Now I'm going to describe extensor tendon management, which is actually similar to as flexor, as immobilization stage is there, passive early passive mobilization is there, early active mobilization is there, but little bit changes is there because zone flexor zone and flexor extensor zone is totally different, because there it's arrangement of zone, sheath, pulley, and muscular structure, everything is different from the extensor zone. So I'm going to describe about immobilization. Immobilization actually divided in 2 stages in the extensor tendon, from MCP to proximal and from MCP to distal. So if injury in zone proximal to MCP, then tendon should be certain position through the splinting for the 3 weeks. Afterwards, finger may be placed in removable volar splint. But if injury in zone distal to MCP, then longer period of immobilization is required. Maybe it's up to 6 weeks. Afterwards, dynamic splint during daytime and static splint we can change into nighttime to maintain the extension. Now come over to early passive motion. This is the reverse protocol actually of flexor tendon. As flexor tendon, we are starting the passive motion from the day 4, but here actually we have to give to the splint only. Extensor are held in the extension by dynamic and gentle rubber band traction will give. With that only we have to do the active flex of the fingers and passively moving the repaired extensor tendon. And splint must have dorsal compartment governing the flexion to inhibit the overstretching or rupture of the extensor tendon, facilitate tendon strain, and can prevent the splint actually will facilitate the tendon strain and can prevent the scarring, which is actually our motto to limit the adhesion and increase the motion or function. Then early active motion. Early active motion, early active SARTAR program allows the tendon to actively move 3 days after the surgery. Therapist must take care to ensure the stress applied by the early active motion does not be overpower strength. It may make the changes in the surgical repair. Sprint program is complex and specific, requires skilled therapist. So in the time of early active motion, you need to do under the observation. Week 3. Now I'm starting from week-wise management. From 0 to 3 week, splinting should be volar and wrist should be in 40 to 45 degree of extension, 0 to 20 degree of MP flexion, and 0 degree of IV flexion. Wound care, edema management, and use of electrical modalities we can do by 0 to 3 weeks for the pain management. And we can start MP joint protective range of motion, PIP and DIP protective range of motion exercise, and removable volar component may be applied sleeping time and intermittently during the daytime to prevent the PIP joint flexion contracture or extensor lag. This is the splint, hand-based dynamic extension splint, which is called as outrigger splint also. Now I'm discussing about week 3. Splinting will be volar same, but wrist will be 20-degree extension, MP will be 0-degree extension, and with PIP extension lag or flexion contracture. If it's there, then use removable volar component with MP joint flexion less than 30-degree to 40-degree with a hard endful. MP active range of motion and active assisted range of motion with tenodesis. If tenodesis movement, you can start. IP active range of motion, active assisted range of motion, and passive range of motion. So complete range with supported support to wrist and MP, you can start. Control passive IP motion also we can start in this stage. Week 4 to 6, splinting will change to dynamic, and MP flexion as needed we can give, and combination of IP and MP and IP traction we can initiate to decrease the extensor tightness, and composite MCP IP flexion with wrist extension we can start by 4 to 6 weeks. Here we can start individual finger extension also, and isolated extensor digitorum communis extension also. By 6 to 12 weeks, composite finger and wrist flexion initiate if no extensor lag is there. If it's there, then we will not go for the composite movement. We have to again go through the individual movement. And mild progressive strengthening exercise also we can start by 6 to 12 weeks, including wrist flexion, extension, forearm supination, pronation, all the movement we can start. And FES, functional electrical stimulation, we can also start by this week. If you are giving the functional electrical stimulation, if up to 6 week also, 6 to 12 weeks, if there is same extensor lag and muscle pull is not that much and tendon heal that much not happen, and same adhesion and contracture is there, then you can give the functional electrical stimulation. With that, tendon healing will be good, and because of strong muscular contraction, tendon adhesion, if it's there, it will be started optimizing. Then week 10 to 12 we can start primers, which I already explained during my first session, as I used it for the assessment, standardized assessment purpose. Here we can again use as a standard training program, as a registry training exercise program also we are doing by 10 to 12 weeks. We can add on primers, which will be give the better changes in the normalizing the hand function. So we are using the primers in the Manipal also. Now, what is the recent advances actually happened in the tendon injury? I'm going to discuss 4 type of recent advances article I got. One development happened is matrix rhythmic therapy. Matrix rhythmic therapy is this article I found in 2014 article, and which is applied for the scar mobilization in flexor tendon injury associated with thermal burn. Matrix rhythmic therapy is type of vibration only, which generally when we are giving the scar massage, sometimes we are using, if more scar girth is there, then we are using the vibration or vibrator for the scar massage. Like that, matrix rhythmic therapy also one type of vibration therapy only. Through the acceleration process, we are giving 8 to 12 hertz of this machine to directly over the scar and to release the to mobilize the scar. And second technique is robotic therapy. Robotic therapy article is published in 2010 to find the scope and effect of a tendon rehab robot of management of hand injury. They use the robotic therapy, which we are actually using for the neuro rehab cases, for mostly for robotic hand therapy or robotic therapy for neuro rehabilitation, that they started using in the hand injury cases. Third is the laser therapy. Laser therapy generally will use for the skin management, but here they are used in 2010 for the soft laser they are using for a positive effect on scar management. Fourth is cryo ultrasound therapy, which is published in 2018. They used for the post-operative inflammation and tendon healing process to get initiate and activated the tendon healing process. They use the cryo ultrasound three different group they build up, and they give the different amount of ultrasound and they compare the three group, and they give the positive result. Now I'm going to discuss about the evidences. This is the first article I'm showing, which is published by Sayani in 2018. Outcome of article name is outcome of early acting mobilization after flexor tendons repair in zone 2 to zone 5 in hand. Methodology she used 34 patients with caught flexor tendon in zone 2 to 5. Post-operative immobilization was done with a splint in 10 to 15 degree of palmar flexion of the wrist and 70 degree of flexion in MCP, and IP in slight mild flexion. So when my colleague Mamuni described about the flexor tendon management, that time she told about the dorsal blocking splint, which keep the IP joint in the neutral position. But here Sayani is changed it to IP joint in a mild flexion. So through that, the rehabilitation program is she made as a modification of cleanup regimen, and result, what conclusions she get, the early acting mobilization of cut flexor tendon in zone 2 to 5 using the modified mobilization protocol has given a good result with minimal complication. My second evidence is primary FS, who is published this article by 2014. Primary flexor tendon repair in zone 1 and zone 2, which is a comparative study. In zone 1, zone 2, she compared the early passive mobilization versus the control active motion. And methodology she used retrospective analysis of the collected data of all patients receiving primary flexion tendon repair in zone 1 and zone 2 from the 2006 to 2011, during which time they got to 28 patients were treated, and 191 from that patient with 231 injured digit were eligible for the study. And during that study, the primary endpoint was the comparison of total active motion value 4 and 12 week after the surgery between the early passive motion and control active motion protocol. Both the protocols he used, and she studied that is any changes in the total active motion value during that weeks. And results he got, there is a statistical significant difference between the TAM value of both early passive mobilization and control active motion protocol of 4 weeks after the surgery. These studies show a favorable effect of control active motion protocol on total active motion 4 weeks after the surgery. This then last evidence of mine is Geeta K, which is published on 2018. Her thesis is on early ultrasound therapy rehabilitation after zone 2 flexor tendon repair. She used here total number of 100 cases and 139 digit with zone 2 flexor tendon injury were studied. After randomization, they administered pulsed ultrasound therapy of different frequencies and intensities according to the doses calculation of total of 72 patients and 99 digit, and formulated 3 groups. And these 3 groups she gave the different frequency of pulsed ultrasound therapy. The result of ultrasound treated cases were compared with each other and with the result of case of the cases treated by the immobilization protocol. Means here 4 groups she derived. 3 is of different type of different intensity of pulsed ultrasound therapy, and 1 with the only immobilization protocol therapy. So with 4 groups she is compared, and she made the result and conclusion, which is after zone 2 flexor tendon repair, pulsed ultrasound therapy during the early rehabilitation phase is safe and effective, and the result is comparable to early mobilization protocol. So showing the good result. Now, what is the factors affecting the healing and rehabilitation mainly? First is injury or surgery related factor. Second is sheath integrity or surgical techniques what one surgeon is doing, and timing of repair, therapy related. If therapy is not started in a good time, and after 1 month of surgery patient came to for the therapy, then there will be already so many adhesion or contracture will be happen. So patient related factor, general health or healing potential, if it's there, then it will be change the healing process. Rate and quality of scar formation, or if socioeconomic factor also sometime may cause. What can the patient do? Patient can implement and do home exercise program as recommended by the therapist, learn how to improve and how to utilize the exercise program, so it will increase the uses of the hand on the under the supervision of the therapist. Strengthen the hand and progress toward the use of full hand function. Set a short and long term goal, rehabilitation goal, which will be give one good effect. Learn how to perform daily activities such as dressing, bathing, grooming, driving, which is in a safe manner, while the hand will be hand is being rehabilitated. Now case study. I'm just giving two case study. One of my case of 26-year-old male, which actually got right wrist due to glass cut, resulting flexor pollicis longus cut, and FDS FDP of index, middle, ring finger, in addition to median and ulnar cut also in flexor zone 4 and 5. After 8 weeks of giving the therapy of post-operative management, showing good flexor and extension grip strength and in-hand manipulation also. And one of my second case, age of 32 years of old male, cut left wrist due to sharp knife cut, resulting FDS and FDP of index and middle finger and median nerve laceration in the zone 5. After 4 weeks of post-operative management, showing a good wrist flexion and extension range, good grip for holding the water bottle and driving scooty also. Now I'm going to show what is the available of advanced training program in the Manipal, which is Primus. Already I discussed about the two things, so which is advancedly we are using FES of advanced version, and one more is Primus. Primus we are generally using for the hand exercise program to develop the grip, pinch, in-hand manipulation, and for the both the strength and functional purpose also. Both physio and OT both are using this. I am showing the videos of small of that. This first video I am showing about the power grip. This we can use first is the for the assessment also, standardized assessment purpose. After assessment we'll get one idea what is the actual value. Actually Primus we are using to check the peak isometric strength. Second is dynamic power value. Third is dynamic endurance value. So three things we can directly analyze from the monitor, which is already attached to the Primus. So with that we'll first check the what is the power.
Fingers touch करके रख ताकि पता चले कि
grip
grip
strength.
कर रहा है.
Grip strength we can check, and after doing this by assessment we can use the Primus. After some session of giving the Primus as a therapeutic basis, we'll get the changes by seeing the again monitor. We can check the details what is which is changed. First we can check with the normal hand and affected hand as standardized protocol, and after giving the therapeutic again we can check with the normal hand and affected hand. So we'll get the pre and post test changes, and we'll get to know what is the changes actually happen, and we can directly tell to the patient this is this many changes happen with the help of Primus. Now second video is pinch development.
उसके साथ चाहिए, resistance के साथ चाहिए. नहीं.
By doing this movement, we can check what is the isometric strength, dynamic power, and endurance. And after giving some session of the Primus also, we can check what is the actually value changed in the patient's ability.
चाहिए, resistance के साथ चाहिए. नहीं.
And day one of assessment and last day of therapy, you can judge that how much is the work done by the patient, and from day one and last day of therapy. So you can directly get from the monitor, and you can directly give the exercise chart, developmental chart to the patient, which is actually documentary. Now this is the supination and pronation graph. Same we can use for the assessment and therapy purpose. This is for the development of spherical grasp. These are the pictures. Different grasp, that is spherical grasp, this is cylindrical grasp. This is the grip strength. This is the pinch. These are my reference, which I used for the topic. Thank you. You can share your questions.
Yeah, thank you. The questions that were asked, especially to Dr. Srikant. Dr. Srikant?
Yeah.
Yeah.
So the first question is why zone 2 injuries are most difficult to treat?
Yeah, that's a very good question. The biggest problem with zone 2 injury is that there are too many structures there. There is a small fibro-osseous tunnel through which the flexor digitorum superficialis and the flexor digitorum profundus go through. Therefore, what happens is that it is very difficult to get a good repair of the FDS, the FDP, and once you do the repair, if you do not give adequate physiotherapy, if you don't mobilize, you don't give good hand therapy, they tend to form very severe adhesions. When you have an adhesion, what happens is the finger does not move. So it becomes stuck, it becomes more and more stuck, and eventually the patient is not able to use his finger. Therefore, zone 2 injuries are have the maximum amount of problem. This can happen with any other zone, like zone 1, zone 3, zone 5. But in these areas, for the tendon gliding is much better because they are not in such a tight fibro-osseous tunnel, and therefore that is why we have most problems in the zone 2.
Right, thank you. So again, which zone has the best result?
Which zone has the
best result?
Zone 5, flexor tendon, zone 5. A wrist
zone
injury, a
5.
spaghetti wrist has got the best possible result. Young children, very good result. Early mobilization, very good result. No wound problems, very good result. Clean cut injuries, very good result. Anything other than these will have a poorer result.
Okay. What happens when both flexor and extensors are injured?
Yeah, that is a good question. It happens quite frequently, especially in a sword fight or a machine injury. Sometimes if there's a crush injury, not only the flexors, extensors, but the bones and the metacarpals also are fractured. So we have to look at it in two ways. One, where there is a bony injury. Secondly, when there is no bony injury. If there is no bony injury, early controlled mobilization is our protocol. We follow the same protocol as it were, depending on the flexor zones, not on the extensor zones. Only thing being is the controlled movement, controlled flexion is going to be a little more gentle, little more slower than in the isolated flexor tendon injury. If there is a bony injury, it depends on the kind of fixation. If it is a sharp cut in the bone, you put a plate, you put a rigid fixation, then we can follow the same protocol as per as there was no fractures. But if the bony fixation is not rigid, that's where the problem is. So what happens is that if the bony fixation is not rigid, you're not able to give good therapy. In that case, I would wait for about 4 weeks, wait for the bony injury to settle down, and then start mobilization. And this mobilization therapy will take on at least about 2 to 3 months before they can have a useful hand function.
Great. Does fracture change any treatment?
Yes, as I just said, the fractures will change the treatment. If you get a rigid fixation of the fracture, then there is no need to worry. You treat it as per as the zone of the tendon injury, because that takes priority. But if you don't have a rigid fixation, or if you have an external fixator, or if there is a vascular compromise, and sometimes you do not know if the hand may or may not survive, then it is wise to withhold therapy for about the first 2 weeks till things settle down, and then start gradual mobilization.
Right. Last question for you is any nerve injury common so far?
Yes, in a zone 5 injury, almost always you will get a median nerve injury and ulnar nerve injury. Whereas in a zone 3, you can get the common digital nerve injury. And in a zone 4, you may get the injury to the nerves which go into the thenar and the hypothenar muscles. All these need to be looked for and repaired. For example, under the carpal tunnel, you miss the motor nerves to the thenar eminence. Then the opposition will be restricted. There will be thenar flattening and the patient will have a ape thumb deformity. Similarly, with a median nerve injury, they will have a low median nerve injury along with clawing of the index and the middle finger. If it is an ulnar nerve injury, they will eventually develop clawing of the ring and the little finger, unless they are in a very young age group where the intrinsics can get regenerated, or if the repair is very good and the recovery is very fast.
Right. Thank you, Dr. Srikant, for this wonderful session of yours.
Thank you.
Now the questions for the OT,
Yeah.
occupational therapist. Hello. Which zone is commonly involved in injury?
Mostly zone 2 flexor tendon injury is common, because zone 2 has so much of complication because of rigid tendon, because of pulleys, annular and cruciate pulley, and second is because fibroosseous sheaths are too tight, it will not allow the tendon to completely glide. Because of that only zone 2 is the difficult for management. If patient is not started from the day one, completely up to 1 month, at least patient need to do the continuous surgery, continuous therapy. If not, then it may cause the adhesion, and after that it may lead to further surgery.
Okay, thanks. So how long should be the immobilization period?
Immobilization period, ma'am, it may differ from patient to patient, but actually it fixed as 3 to 4 weeks as a month. If patient is coming with more of complication with other injuries, like not only tendon injuries, nerve injuries there, fracture is there, or any ligament injuries is there, then it may change to 3 to 4 weeks to may proceed to 6 weeks also.
Okay.
It may
When
change.
to start? Okay. When to start FES? Functional electrical.
Yes, you can at least you have to wait for the 6 week. As per the evidences I got from the Google Scholar, researchers are showing that up to 6 week you have to wait. Up to 6 week, actually you have to give the tendon to properly heal. Once it will be start healing, then they can control. If you are giving the FES to the one certain muscles, that muscle will start giving the vigorous contraction. If tendon is not completely healed, then that contraction may cause the again tendon rupture. So you have to wait for the 6 week to heal. After that only we can give the FES.
Right. And is there any criteria to start primus treatment?
Minimum patient need to have 4 muscle power 4. If muscle power 4 is there, then only we can start assessing the patient with the primus, and we can use also primus as a therapy protocol.
Right. Okay. And why dorsal blocking splint is preferred?
Dorsal blocking splint, ma'am, actually in dorsal blocking splint, already Mamuni discussed also, I also told, same dorsal blocking splint will give the wrist in supportive flexion of 30 to 40 degree, and MCP in 50 to 60 degree of flexion, and IP in neutral, sometime in mild flexion, which will protect your flexor tendon to heal first, second to prevent the adhesion, third it will give the proper tendon gliding of the in that position. In immobilization position also it will give the proper place to tendon to glide and tendon to heal. This is the main reason we are giving the dorsal blocking splint.
Okay, we still have more questions to both Dr. Srikant and you guys. There's one question which is like, what's blocking exercise? Can you explain it clearly in brief?
What blocking exercise? As she told also, there is actually two types of blocking exercise. First is you can go as generalized, which is just give me 1 second. Can I go through slide? Where I have to go?
You can just brief it out. If
Yeah,
it is
show the
long,
picture, so it will be easy to understand. Yeah, this is the differential tendon gliding. Actually, when patient will come to 4 weeks, generally we'll start doing the differential tendon gliding, where we'll tell the patient to straight finger. If patient is not able to do, you can passively help also to do the patient to maintain the straight, and hook fist, then straight fist, then full fist. This is the 4 gliding exercise. Generally we start firstly when the 4 weeks will start. If patient is not able to do from full fist to straight hand, then up to that your therapy program is not finished. You have to continue, or you have to tell the patient to continue the therapy program. Still patient is actively getting the straight to full fist. So 4 gliding position is there, from straight, hook fist, straight fist, then full fist. 4 position. This is the differential tendon gliding. One more is, as Mamuni told, there is isolated tendon gliding or blocking exercise is there, which is for FDP and FDS. You can tell the patient to put palm over the table, and you have to block both the fingers and do the finger flexion. Means FDP you will glide isolatedly. Then you will support the PIP, and you will support the proximal phalanx, and you will do only DIP joint movement. That time your isolated FDS will glide.
okay. And then there's another question. There's one question where FDP is also crossing the PIP joint. So how will we differentiate whether FDS is injured or not at the level of PIP? Because FDP flexed the PIP as well.
FDP and FDS.
Yeah.
Okay.
In FDP is crossing the PIP joint.
Yeah.
And if this FDS is injured, then I'll just repeat the question again. FDP is also crossing the PIP joint.
So how will we differentiate
whether FDS is injured or not
at the level of PIP?
Because FDF flexion the PIP as well.
There you can do like PIP joint, both the tendons are crossing here. You can do DIP flexion when you are doing that time your FDS. Hello?
Yeah, please go ahead.
FDS is working. That time you have to control over the only DIP joint flexion you can do isolatedly. That time you have to hold the middle phalanx also. Only passively you can do the DIP movement.
Okay. So these are the questions for today. Thank you, Dr. Swarna and Dr. Mamuni as well for this insightful session. So I thank all three of you for a wonderful and knowledge-giving session so far. So the vote of thanks, I would like to thank Dr. Dheeraj Adigas, HOD PMR, Dr. Manish Rai, Director Manipal, Dr. Kshitija, DGM Operation, Dr. Dhanlakshmi, Manager of Physiotherapist, Dr. Viruchi Varshine, Dr. Ramya Sendil Kumar, and the entire state of IAP and IAPWC Karnataka.
Ma'am, if any questions is there, then you can share through the email, so we can get back to that answers.
Yes. Yes.
Doc-
So we would get back
Dr.
to you
Srikant,
with the mail ID. Thank you, all of you. But before we sign off, the topic for tomorrow is about the role of critical thinking in physiotherapy by Dr. Kavya Rasu. The session will start at 5 o'clock. Please register. You will follow. There will be a link followed. Please kindly register and log through the video. Yeah. So we shall end the session for today. Thank you, everyone.
email
for the-
ID, ma'am, I have to tell or?
Yeah, please tell the email ID as well.
Dr. Srikant, the email ID is drsrikantv@gmail.com.
Okay.
And mine is swarna.lima@gmail.com.
Right.
And Mamuni behera.06@gmail.com.
Okay, I think that is noted. Yeah, thank you all of you for the participation as well. See you all for the session tomorrow.
Thank you so much, ma'am. Thank you so much to all the audience. Thanks to IAPWC Karnataka branch, and thank you to Manipal to give me the opportunity to speak over and explain about my experience in the tendon injury.
Thank you,
Do you
ma'am.
understand all this topic? If any doubt, please give the feedback or questions to the mail.
Thank you.
Thank you.
So we shall conclude the session for today.
See you.